illnesses that affect the bowel or the GIT, starting from the oral orifice to the anal orifice, usually long-lasting, and come in two different categories. The major two differences are either ulcerative colitis or Crohn's disease. هذا الشيء المعروف عن الانفلاماتوري bowel disease. وين ما نسمع عن inflammatory bowel disease or IBD means either Crohn's disease or ulcerative. There are certain differences between them and there are certain similarity between them. The management of these two illnesses are also the same nearly, but differ in surgical intervention. Medical treatment is a little bit the same, while the surgical treatment is a little bit different. So Crohn's disease and ulcerative colitis, the same category, they are called inflammatory bowel disease that cause a chronic inflammation of the gastrointestinal tract. أهم شيء إنه هي شنو؟ chronicity first of all. ثانيا, there is no isolated microorganism leading to that illness. So chronic inflammation, what does it mean? Impairment of the ability of the affected organ to function properly. أكو مشكلة بالabsorption and مشكلة بالbowel motion, leading to symptoms such as abdominal cramps, diarrhea, rectal bleeding, and fatigue. Inflammatory bowel disease affecting small and large bowel. The main forms of inflammatory bowel disease, as we said, is either ulcerative or Crohn's. Ulcerative colitis in this way. This is the pointer, as we said. Ulcerative colitis in this way.
دكتور العفو بس السلايد ما جاي يتحرك.
ما جاي
بعد على
يتحرك.
أول سلايد.
اوكي ماكو مشكلة. Bowel disease affecting the small and large intestine, and they are usually in either main two forms, which either ulcerative colitis or Crohn's disease. Ulcerative colitis, a mucosal involvement in this way and in a continuous manner. Crohn's disease, an interrupted inflammation in this way. البوينتر واضح؟
اي واضح دكتور.
ممتاز. And all the thickness of the bowel is involved. The main differences between the Crohn's disease and ulcerative colitis is, first of all, location. As we said, the Crohn's affect the GIT from the mouth to the anus with a high predilection to the terminal ileum, while ulcerative colitis involvement from the rectum and spread proximally to all the colon without involvement of other parts, the small intestine, apart from mild involvement of the terminal ileum, as we call it, backwash ileitis. Microscopically, ulcerative colitis is restricted to the mucosa, while Crohn's disease affecting transmural involvement. Crohn's disease and ulcerative colitis presented an extraintestinal manifestation with the predilection of each form and each type to certain areas, like ulcerative colitis mostly involving the choredochal regions and the biliary involvement in a sclerosing cholangitis, while Crohn's disease mostly affects the eye with a scleritis and episcleritis. And rarely a definitive diagnosis of neither Crohn's disease nor ulcerative colitis can be made. ليش? Because of the idiosyncrasia in the presentation. In this case, a diagnosis of intermediate colitis may be made. نوبات لا هذا ولا هذا. But certain involvement, we call it either intermediate or we call it non-specific. Ulcerative colitis is an idiopathic form of a colitis that include characteristic superficial ulcers, as we said. The main symptom is diarrhea, which either mixed with blood or mixed with mucus, and sometimes mixed with pus. Ulcerative usually is an intermittent disease, مو بالinvolvement ولكن بالsymptoms, with a period of an exacerbated symptoms and a period that are relatively symptom-free, يعني relapse and remission. Ulcerative colitis, however, it is a systemic disease that affects many parts of the body, as we said, intestinal and extraintestinal manifestation, involvement of the ulcers in this way. All the bowel wall are involved, but it is a superficial form. The epidemiology, the incidence of an ulcerative colitis in North America is about 10 to 12 cases per 100,000. Peak incidence of ulcerative colitis between age of 15 and 25. هذا الحكي in certain references. In other references, they said between 20 and 40. This is the first peak. A second peak in the 6th decade. يعني انتم بعدكم ما زلتوا in the young age group ممكن يصير involvement and presentation in this time. تعبر ال 40, you should be immune of that illness, but you will have a second peak in the 60s. And the geographic distribution of ulcerative colitis and the Crohn's disease is similar worldwide. أكو عدة presentation and عدة explanation of that similarity in certain areas and predilection of these illnesses, as we will see. The predilection is in the North America and Europe, the Western Europe, at the highest degree, with an intermediate one in the South Africa and Australia, and also in the Japan. There are many theories about that distribution. Certain says that may be related to the food type and also industrial work and in certain causes. The most related people is a Jewish, relate Ashkenazi Jewish persons, سامعين بيهم Ashkenazi Jewish, and a certain presentation in Israel. The problem in that is their food stuff and food material may be the cause of that form, with the certain point that any country with changing in their lifestyle toward the Western type, they have an increased incidence of an ulcerative colitis, followed by an increased incidence of a Crohn's disease. Fetchy, amazing. The difference between an ulcerative and the Crohn's, as we see here, the ulcerative involve all the colon and stops in the terminal ileum, while in the Crohn's disease, it's involved the ileum and then separate in the colon, a diffuse mucosal inflammation with superficial involvement, while in the Crohn's, it is only the skipped lesions, as we said, but may involve any parts in the GIT. Affect rectum, may affect any part of the GI, and may involve all parts of the rest of the colon. In Crohn's disease, it is a segmental involvement. Ulcerative colitis is a mucosal inflammation of crypt abscess. هذه الكريبتس اللي يصير in the bowel, it has an abscess, and there is an erosion. These areas are erosions in the colon, along the colon, with an ulcers. We call it a snake ulcer. A key feature of an ulcerative colitis is a continuous involvement of rectum and colon, كله involved, and does not involve ileum, apart from mild backwash ileitis and flat dysplasia, a pre-malignant condition, with an inflammatory pseudopolyp. These are pseudopolyp. Classification of an ulcerative colitis normally continuous from the rectum up to the colon. According to the extent of involvement, we have proctitis or proctosigmoiditis, first to start with, all left-sided, all the descending colon colitis, or subtoral, and even toral involvement. The pancolitis, plus minus backwash ileitis, as we said. According to the course, we have either an acute illness, culminant colitis, or intermittent course, as we said, with exacerbation and remission, or a permanent progressive. An endoscopic grading of an inflammatory bowel disease, we have a loss of vascular appearance, الكولون يصير شكله pale, and erythema, redness of the mucosa and the friability of the mucosa on contact bleeding, يصير بالعكس congested, or superficial ulcers, and may be confluent one with each another, or presence of a pseudopolyp. These are many types of classifications, or according to different degrees. Severity, we have either mild, fewer than 4 stools per day, with or without blood, without systemic features, moderate, more than 4 stools, with a minimal sign of toxicity, patient display anemia, or severe, more than 6 blood stool per day, and evidence of a toxicity is demonstrated by a fever and tachycardia. Local complication, we can have toxic megacolon. It is a pathological dilatation of a colon, especially the transverse colon, of more than 6 centimeters, with the presence of sign and symptom of toxicity, like dehydration, tachycardia, fever, inability to pass motion. We call it toxic megacolon. Or perforation and peritonitis, or profuse bleeding, or fat dysplasia and malignancies. These are the local sequelae and complication of illnesses if it's not treated or untreated well. The extraintestinal features, we have anaphthous ulcers of the mouth, an ophthalmic involvement of the eye, iritis episcleritis, musculoskeletal seronegative arthritis, or we call it seronegative spondyloarthritis, which can be in large joints, oligoarthritis, affecting one or two joints, ankylosing spondylitis, the characteristic features of ulcerative colitis. The most extraintestinal manifestation is an ankylosing spondylitis, or cutaneous, like erythema nodosum or pyoderma gangrenosum, deep vein thrombosis, coupling, and others. This is the local complications. Here we have dilatation toxic megacolon, and also we have a perforation with a collection of an abscess, and these are malignant changes, strictures, malignant strictures, and also some sort of a dilatation here. This is an extraintestinal manifestation of a toxic ulcerative colitis. This is a perianal involvement, pyoderma gangrenosum, and erythema nodosum. Fulminant ulcerative colitis, BMI less than 16, pathological, because the normal BMI below 19 considered abnormal. It should be started from 19 to 25, with extraintestinal features and the complications. This is a fulminant, had a patient before operation, patient with a colostomy, a little bit become wear, and now his BMI is 19. Ulcerative colitis intestinal complication. This is, we call it a snake ulcer. It is one form of a narrowing of the lumen. This lumen narrowing due to edema and ulcers of the lumen leading to the narrowing. This is the first degree. Then after that, destruction of all the lumen by a progressive process with the dilatation and the presence of a pseudopolyp. In this way, we call it a cobblestone. Risk of colorectal cancer. Every 10 years, we have an increment about 0.5 per year in the first 10 years. It a little bit change to another 0.5 in the next 10 years, and also in the others. So first of all, in the first 10 years, we have a 2% percentage of an illness or a tumor. In the second 10 years, we have about 10 or 9%. In the third decade, we may have a percentage may reach 20%. Well, this is the normal control percentage of having a tumor or malignancy of the colon. The clinical presentation of an ulcerative colitis depends on the extent of the disease. واضح. Patients usually present with diarrhea, cardinal symptoms, diarrhea, mixed with the blood and the stool of a gradual onset with the weight loss. They also may have a sign of weight loss and blood on rectal examination. Disease is usually accompanied with different degrees of an abdominal pain, from mild discomfort to severely painful cramps. The following condition may present in a similar manner as an ulcerative colitis and should be excluded. Certain illnesses that may have a differential diagnosis with the ulcerative colitis: Crohn's disease, infectious colitis, pseudomembranous colitis, Clostridium difficile involvement, ischemic colitis, radiation colitis, and a chemical colitis. Diagnosis and workup. طلابنا واضح الصورة والصوت؟
اي دكتور واضحة.
ممتاز.
والله دكتور.
كل زين. Diagnosis and workup. The diagnosis depend on the general features and general investigation, like a complete blood count, electrolyte studies, and minerals and vitamin disturbances, liver function change. We have also an X-ray, that is the most important form of diagnosis in barium enema. Urinalysis also leaves a proteinuria. Stool culture rule out parasitic and infectious involvement. Also others, ESR and something selected protein. And the gold standard tool of investigation or diagnosis is colonoscopy, with the revealing of the characteristic edema and ulcers in a continuous manner from the rectum and goes proximally. This is a feature of or involvement mucosa by the colonoscope, and these are the cobblestonic and narrowing of the lumen with the ulcers by a barium enema, with the disappearance of the normal hostra, and this is a biopsy, continuous involvement of the colon all over the large bowel. Treatment, we have two types of treatment and two modes of treatment, either medical and surgical. The medical treatment is about the aminosalicylates. In 1977, 5-aminosalicylic acid is a medication that's important for the management of ulcerative colitis, and it is a form of immune modulator. Was a therapeutic active component as sulfasalazine. It has many brand names, sulfasalazine, like pentase, mesalazine, asacol, and others. Sulfasalazine, also known as azilfidine. These are known forms of 5-aminosalicylic acid. All of them belong to the same family, a form of immune modulator that leads to the downstaging of that illnesses. And we may have a control of the illness by that medication, and it is a chronic illness. Corticosteroids also has a good effect and has a magic effect and can be used for an intermittent course, or it is cornerstone treatment in active fulminant illness, like a cortisone, prednisolone, and hydrocortisone. And immunosuppressive drugs also have a good rule, like mercaptopurine, 6-MP, or methotrexate, Imuran. Biological treatment also of a good involvement and a good management, like infliximab and vicilizumab. Well, helminthic therapy, it is an experimental. Currently, two closely related treatment available, either inoculation with a nectar americanus, commonly known as hookworms, Trichuris suis ova, and commonly known as pig wipeworm egg. Conditions that require immediate surgery, the second option in the treatment of ulcerative colitis is sudden, severe ulcerative colitis. This is the main reason for emergency surgery in ulcerative colitis. يعني عادة يكون first presentation usually a sudden severe abdominal cramps with bleeding and mucus discharge. This is, we call it sudden fulminant, and also in certain uncontrollable type and persons over the medical treatment, we can use surgery as a substituted solution. About 15% of people with ulcerative colitis have an attack of the disease so severe that medication, even intravenous steroid, cannot control the symptom. يعني خلي ببالك في الفكرة إنه the routine and daily measures of treatment is 5 ASA, sulfasalazine, mesalazine, pentase, and others. من يصير عندنا sudden هذا for daily treatment من يصير sudden increment of illness on abdominal cramps and diarrhea and bleeding, we should use steroids, either an IV or oral or local by enema. في حالة عدم فائدة الإنسان من oral medication السلفاسلازين group or steroid, we should go to the operation and surgical solution. وهذا يصير in 15% of patient in the first presentation. Surgery may be necessary if a medication is unable to bring the attack under control. Sudden severe ulcerative colitis also includes uncontrollable bleeding of the colon, which is quite rare. Toxic megacolon, مثل ما سولفنا على development of a local complication also. Toxic megacolon, severe inflammation that lead, as we said, dilatation with toxicity. When surgery is necessary, about 23 to 45% of people with ulcerative colitis and up to 75% of people with Crohn's eventually require surgery. Some people with these conditions will have an option to choose surgery, while for others, surgery is an absolute necessity due to complications of their illnesses. These are some sort of sequelae, as we said, erythema nodosum and pyoderma gangrenosum. Indication for surgery, the absolute, 4 رئيسيات: fulminant colitis, local complication, toxic megacolon or bleeding or perforation or carcinoma, or growth retardation in pediatric patients, اللي هم young age. Relative indication, progressive course of disease, intractability despite medical treatment, clad dysplasia, means pre-malignancy, and pseudopolyposis. This is a form of medication if we have an illnesses, blockage of the rectum, and removal of all the rectum and the colon with the ileostomy. This is a J pouch and re-anastomosis. This is an ileum. We form it in a J shape, half J, with an anastomosis with the anal canal. And this is an also a little bit bigger pouch. This is, we call it J pouch. And this is a bigger, we call it S pouch, with an anastomosis 2 times, make it a pouch bigger. هذا يصير عندهم frequency more than 10 to 14 times per day, and this may reach to 5 times per day, just like a normal person, and it may come less over the time. Crohn's, also known as a regional enteritis. It's a chronic episodic inflammatory bowel disease, affect any part of the entire wall, as we said, not a superficial, just like ulcerative. Ulcerative superficial, Crohn's entire wall. And the Crohn's disease can affect any part of the gastrointestinal tract, unlike ulcerative. As a result, the symptom of a Crohn's disease vary, ليش? According to the site that is affected. Although the cause of a Crohn's disease is not known, it is believed to be an autoimmune disease and is genetically linked to a mutation of CARD15 and NOT2 genes in the body. Highest relative risk occur in siblings, affecting males and female equally. Smokers are 3 times more likely to get a Crohn's disease, unlike ulcerative. They have a less time among smokers. So smoking acts as a protective factor from ulcerative, but increase the incidence in Crohn's disease. المدخنين كيفين انه تقل عندهم كرونز بس راح يصعد عندهم الالسراتيف او بالعكس سوري reverse. Clinical features and course of the disease. Symptoms of Crohn's disease, as we said, differ according to the involvement of the site and typically include abdominal pain, diarrhea, weight loss. Systemic symptom of malaise, anorexia, fever also involved. Surgery is not a curative. هذه مهمة جدا المعلومة. ليش؟ لأنه in ulcerative colitis, our operation is the treatment of choice in certain illnesses that are not controlled by medication, and it is a curative. We do proctocolectomy with ilioanal anastomosis, we are free from illness. While in Crohn's, whatever we do, whatever we resect, the illness is persist and it may recur again in a previously healthy colon and bowel. واضح? Surgery is not a curative and management is directed to the minimizing the impact of the disease. At least 15% of patients may require a surgical treatment in the first 10 years of the disease. عمليات اللي تصير بالكرونز هي أكثر ولكن الفائدة من عندها أقل. واضح طلابنا؟
واضح دكتور.
ممتاز. This is some sort of the percentage of involvement. 50% ileocolic, 20% colic, and 30% eagle. This is the pathology gross, transmural involvement. This is granuloma, and this is a snake ulcer with the patchy involvements. It's also the same, and this is an extraintestinal manifestation, and the crypt abscesses in the anal region and in the perianal abscesses, and this is the ulcer also. Clinical manifestation, there are 4 main clinical manifestation. Terminal ileum involvement, we have an appendicitis-like picture. Colonic involvement like ulcerative colitis, diarrhea, abdominal cramps with a bloody discharge. Perianal fistulas and abscesses, as we see here. Extraintestinal features like the skin manifestation, eye manifestation, and arthritis. We have Lennard-Jones algorithm for CD, Crohn's disease differentiation, either segmental, non-involved mucosa, surrounding the involved mucosa, يعني skip lesions, terminal idiitis, deep snake ulcers, fistulas, anal perianal involvement, or granuloma. The diagnosis, any 3 criteria from 1 to 6, أو بس الجرانيولوما plus any one of that other 6. This makes the diagnosis of Crohn's disease. لو granuloma وحدها by biopsy with any one of others. لو the rest 3 should be present to diagnose Crohn's. Also diagnosis either by colonoscopy or biopsy. This is an involvement lesions, and this is skip lesion, and this is the involved on other sides with a skipping, or by enema, the transmural involvement with the thinning of the bowel in double contrast agents. CD diagnosis, snake ulcer. Crohn's disease activity index، هذا مو الا تفتهمه شنو، بس تعرف انه كل ما يزداد عندك الاكتيفيتي index كل ما you have a more severity of illnesses. Remission less than 150, mild 150 to 250, moderate 250 to 350, severe more than 350. A local complication, a perianal abscess, fistulas, toxicity in megacolon, and tumors. Indications for surgery, like in ulcerative colitis, we have an intractability, intestinal obstructions, intra-abdominal abscesses, fistulas, fulminant means local sequelae or growth retardation, or extracolonic severe manifestation that is not controlled by normal routine oral medications. Surgical options for intra-abdominal disease, open or laparoscopic assisted. The mode of treatment in Crohn's disease is a little bit different than ulcerative. In ulcerative colitis, قلنا the treatment of choice is proctocolectomy with either ileostomy or ilioanal anastomosis. اما هاي قلنا عليها J pouch or S pouch. Crohn's disease ما راح نستفاد من الكولكتومي لانه شمن نشيل راح يرجع. So our surgery and our intervention in Crohn's disease should be as limited as you can. like either resection of the affected segment and reanastomosis, or even structuroplasty that we'll see, or colectomy and ileostomy in severe fulminant total involvement of the colon. Crohn's cannot be cured by surgery, though it is used when a partial or full blockage of the intestine occurs, mesenchymal obstruction. Surgery may also be required for a complication such as an obstruction, fistulas, abscesses. يعني احنا نسوي عملية for drainage of abscess أو نسوي عملية for perianal fistula. هذه okay, it is an operation. Does not respond to the drug within the reasonable time. After the first surgery, Crohn's usually show up at the site of resection, so it can appear in other locations. يعني احنا ممكن انه قد ما ناخذ safe margin around the ulcer for Crohn's disease with the resection and anastomosis, at anastomotic line there will be recurrence of illness. ترجع مرة ثانية من تسوي مثلا operation for fistula in Crohn's disease and you do excision of the affected segment with reanastomosis, and you will have after few time, like 1 year or 2 years, a fistula on the same site. You should go for the anastomotic line, and in certain times you may find an involvement of the bowel at that time, at that site. After the first resection, another resection may be necessary within 5 years. هذه الإليوستومي, and this is fistulas. This is a structuroplasty, as we said. One mode of involvement of operation to the bowel is structuroplasty. تحاول تبقي as much as you can of the bowel. So when you have this structure, this is the structure, you should use a longitudinal incision around that structure, and you make it, pull it apart from both sides, from here and from here, just like this way. And your suture line should be in a transverse manner to close the bowel in this way. This is, we call it structuroplasty or hemicolics. Crohn's colitis, high risk of recurrence. So we should do either segmental colectomy or colectomy and colostomy, subtotal colectomy and ileostomy, and ileorectal anastomosis. This is size of recurrences. These are the perianal fistulas and abscesses. Usually in perianal involvement, we have multiple fistulas. When you see a patient with fistula in ano or عنده one opening, it is unlikely to be a Crohn's. ولكن من يجي عنده 2 openings, 3 openings on the same session with the presence of an abscess in the same session, it should raise a suspicion of a Crohn's, and we should make a workup for our patient to exclude the Crohn's disease as early as possible. This is also a perianal involvement. Investigations, also the full blood counts, urea electrolyte, liver function is an important. Serological markers also have some sort of a significance. Fecal calprotectin as a curate in detecting colonic inflammation and can help identifying functional diarrhea. The microbiological tested for Clostridium difficile for exclusion of pseudomembranous colitis, and cytomegalovirus should be considered in severe refractory colitis. Recommendation for cancer surveillance, as we said, in the first decade after 10 years of colitis, annual or biannual surveillance, colonoscopy with multiple biopsies at regular intervals should be performed. The finding of high-grade dysplasia in flat mucosa confirmed by expert pathologist review is an indication for colectomy, whereas finding of low-grade dysplasia in flat mucosa may also as an indication for colectomy to prevent progressive high-grade neoplasia. As a summary, indications for surgery for ulcerative colitis, disease complication, failure of side effect of medication, restorative proctocolectomy, as we said, with ileal pouch anal anastomosis, gold standard for an elective surgical treatment, say be curative. Morbidity is still high. However, transanal mucosectomy with a hand sewn anastomosis versus double stapling, diversion versus not diversion, an indication for surgery in terminate for colitis and can be still debated, remain under active investigation. معلومة مو إلا تفهموها وتحفظوها بس مجرد تطلعون عليها. هذا percentage of involvement either proctitis or proctosigmoiditis or left side colitis or pancolitis, ulcerative colitis. Comparison of features: depth of inflammation, transamural mucosa through Crohn's or ulcerative, pattern, skip lesions in Crohn's while it is an ulcerative continuous, location mouth to anus colorectum, rectal involvement less usual, ileal disease very common in Crohn's and pachycephalitis only in ulcerative, fistulas are common or perianal disease and the same thing, granuloma, diagnostic features of Crohn's, overt bleeding less, malnutrition more common, cancer risk the same, tobacco use harmful in Crohn's, protective in ulcerative. Also, skip lesion is highly presenting, couple stoning also, while crypt abscess in ulcerative colitis. As we said, indication for surgery ranging from 5% in those patients with proctitis to 50% in those patients with very severe attacks. Need of surgery is highest in the first year after the disease onset. For أهم شيء severe fulminant disease ما يستجيبون للميديكال treatment, chronic disease with anemia and frequent stool urgency antithemus ما قاعد يصير control للsymptoms, steroid dependent يظل على oral or IV steroid, neoplastic changes, severe extraintestinal manifestations uncontrollable on medications, and rarely severe hemorrhage or stenosis causing an obstruction. The same thing for Crohn's disease. And these are a picture of Crohn's with all its sequelae. This is the same thing in ulcerative and bone involvement, sacroiliitis, and thank you.